So the client we'll be working with is 41-year-old Andrea. Andrea is a keen runner, and to put into perspective, Andrea has completed 2 full marathons and 5 half marathons in the past 10 years. However, she's now come to us today presenting with ongoing right-sided patellofemoral joint pain for the past 6 months. Since it started, she's reduced her running to a total of 20 to 25 kilometers a week, split across 5 days. But over the past 4 weeks, she's cut down to 10 kilometers a week, split across 3 days due to the pain, which she describes as a dull ache underneath the patella, aggravated by running more than 4 kilometers at a time, going downstairs and kneeling on the floor. She's also mentioned that she has a history of bilateral Achilles tendinopathy, which previously flared up when she's trained for long distance events of greater than 10 kilometers. But in conclusion, Andrea wants to reduce her pain to allow her to run a half marathon in 6 months' time. So PFJ is essentially pain underneath around the patella and the patellofemoral joint that is often due to overuse rather than a singular traumatic event, but can be due to either, with the location of PFJ circled in green on the left. Often people with PFJ will have pain aggravated by movements such as running, walking up or downstairs, and squatting down. Now, as it can vary case by case, PFJ is thought to be caused by anatomical differences between the hard and soft structures of the knee, i.e. bone to soft tissue, causing abnormal patella tracking and therefore irritation of its surroundings. And as research shows, it's often due to factors such as poor neuromuscular control of the quadriceps, in particular a delay between the activation of the vastus medialis and lateralis, also seen in the diagram here in pink and orange. Muscular tightness of the lateral structures such as the ITB circled in blue, and biomechanically, excessive femoral internal rotation, knee valgus, and excessive foot pronation, which can be due to certain muscular weaknesses in the lower limbs. And finally, for PFJ, monitoring training load is important as higher loads can in fact exacerbate it. So now we're going to take a look at a series of clinical assessments that have been done on Andrea. Starting with orthopedic testing, we had the McMurray's test with both sides presenting as negative. We can rule out the possibility of a meniscus tear on both sides. And for the Thomas test, it did display as positive on the right, which can indicate to us that Andrea does in fact have hip flexor tightness on the right hip. Okay, now to range of motion testing. Starting from the top and working our way down, we see 5 degrees dorsiflexion on both sides, which is quite reasonable, but in comparison to normative data is below norms. A deficit in right plantar flexion of 5 degrees compared to left, which is still also quite good. Knee flexion had a 15-degree deficit in the right knee, which can be suggestive of the dull ache Andrea experienced at end range. And knee extension had full range of motion on both sides, and hip extension showed a 10-degree deficit in the right hip, where both sides are actually below norms. Now moving to manual muscle testing, and starting with knee extension, we see a strength deficit on the right, with that dull ache presenting again on that side at a 4 out of 10, which as a whole was really quite expected for PFJ. Knee flexion was good on both sides. Ankle inversion then had a deficit on the right, and another deficit on the right, but this time for hip extension with a bent knee, but had no deficit when the leg was straight. This indicates to me that Andrea is presenting with glute max weakness on this side. For hip abduction, there is a slight deficit in the right also. So for functional testing now, knee to wall showed a 5 centimeter deficit in the right ankle, but was poor for both in comparison to norms, and displayed a 2 out of 10 pain in the patella when doing the right side. For 6 RM single leg press, there was a 15 kg deficit in the right leg with a 5 out of 10 pain. For single leg squat for technique, there was a noticeable Trendelenburg sign on the right, excessive pronation on both left and right, and this caused knee valgus also, indicating a few areas of weakness, but in particular hip abductors and foot inverters. Standing single leg calf raise for reps can be improved on and actually presented with a dull ache in both left and right Achilles. And for power, we see in the single leg hop for distance quite poor results for both sides really. With 10 centimeters less on the right, there was mild Achilles discomfort on both sides during takeoff and a 5 out of 10 pain in the right kneecap during landing. So for goals for both myself, the practitioner, and Andrea, the client, we can start with Andrea's. So in the short term, she would like to reduce pain in daily movements such as squatting, down or kneeling, and to be able to run pain-free. This was her biggest concern. In medium term, she wants to be able to run the half marathon in 6 months' time, but ensure that she had good physical preparation in the build-up. And long term is to be free of patellofemoral joint pain. Now, for my goals as a practitioner, these are based off of Andrea's, but are thinking a little more clinically now. Short term is to educate, reduce pain rather than eliminate at this stage, increase range of motion in many areas of the lower limb, same goes for strength, and recognize current aggravators and minimize them. Medium term is to meet all these goals prior to comp, have a very precise control of training load with progression, and to, of course, be physically and mentally ready for the marathon. And finally, for long term, is to be physically better than pre-PFJ, ensure no concerns, and to have a full return to running. So here is what I would be taking Andrea through in an initial session, targeting the hip, knee, and ankle in both strength and ROM due to the many deficiencies seen in her clinical assessments. Starting in the warm-up with a low-intensity continuous assault bike to increase blood flow and muscle temperature, and dynamic movements afterwards very specific to the main session, lasting 7 to 10 minutes in total, providing a significant and appropriate warm-up as per literature. For cooldowns, there were static stretches that involved the lower limb that was worked, but also targeting deficits in her clinical assessments and what was crucial as per PFJ, as per the current literature. To the main session now, I used rest periods for strength work, which was found necessary due to the nature of the exercises, providing enough recovery time in between. Intensities and repetitions were kept broad and will depend on Andrea's pain or strength, but still enough to challenge. And sets were between 2 and 3, following guidelines for strength and an individual at this level. But for exercises, first off, we have banded inversion as the calf rests over a foam roller, addressing her deficit and asymmetry in these muscles, which have also been shown by research to be a key element in PFJ. Banded crab walk to work hip abductors, important for running performance and for PFJ, whilst improving her Trendelenburg, shown to be key as per research again. Glute bridge holds for glute max and hamstring strength, targeting PFJ and the MMT weakness, but in general, as current evidence shows, is key for high-level running performance in any facet. Now, a leg extension machine working at a moderate intensity and slightly slower tempo to avoid movements that could aggravate the PFJ, as movements like this in her testing were shown to do so. Therefore, sticking to pain lower than 4 out of 10 as research shows this is okay. But in general, this exercise targets the poor neuromuscular control and weakness between the VMO and vastus lateralis for PFJ. A single leg RDL now, as this is a tolerable position for Andrea as per her testing, therefore pushing for more complicated bodyweight movements, testing balance, coordination, and hamstring strength, important components for sport performance and the musculature for her running. Now to a standing double leg calf raise with dumbbells, again slower tempo at a moderate intensity, now for her Achilles tendinopathy. However, will be important to address due to weakness and asymmetry, and again a key factor in running performance. In total, this session should take no longer than 60 minutes. So for some progressions that I'd be looking to make, what I've broken up into 2 parts here. So initially we'll be pushing to restore ROM to or above norms whilst regaining symmetry, and same goes for strength, as this will be crucial for PFJ and Achilles tendinopathy, as shown in the research, whilst looking to improve running performance and prevent future injury. This can be done by exercises now becoming more isotonically focused for strength, as it will progress to a normal tempo, provided it can be handled for some of the exercises. Also progressing from lower level exercises to higher, such as machine work, to more barbell and harder versions of the exercises. And we'd be looking to progress running load to normal now through distance per session. Once these have been achieved, the final stages of rehab as per research, add plyometrics for power and addressing those deficits, concurrently promoting future injury prevention, adding eccentric loading on the necessary tendons and muscles now for extensive injury prevention, Definitely adding sport-specific movements for her running, important for her performance, and now looking to increase total weekly running loads in order for comp preparation. Noting that progressions will only be made when the pain is at or less than 4 out of 10, and we'll work under that space during the sessions.